Greetings, everyone. Welcome to the 175th session of the online Optom Learning Series, OOLS. And for today's session, we have with us Dr. Keran DeLoss. Dr. Keran is an assistant professor at the University of Michigan. She is also a fellow of the American Academy of Optometry and a fellow of the Scleral Lens Education Society. Her special interests are within scleral lenses, fitting irregular corneas, and also dry eye management. She holds various positions, has been chairs of various organizing conferences, as well as teaching activities. And today she's going to share with us her journey or her thoughts about keratoconus and how to go about managing patients with keratoconus as well as other corneal ectasia. So welcome, ma'am, onto our platform. Thank you so much, for joining us on this Sunday morning from the US. And let me just leave the screen time to you.
Thank you so much for having me and inviting. I really, really appreciate it. I'm excited to talk to you about keratoconus today. It is one of my areas that is near and dear to my heart. So I'm going to try to just run through everything. I hope I get through all of my slides. So with that, let's get started. So I have no financial disclosures. And objectives today are, I want you to be able to have a take-home points of understanding corneal ectasia and, sorry, let me just adjust my screen so that I can see. I want you to have a full understanding of keratoconus as well as corneal ectasia. I have an understanding of the pathophysiology, a complete understanding of the diagnosis and the detection with corneal imaging, and understand key clinical considerations of treatment options. So keratoconus is a non-inflammatory condition of the thinning that causes thinning of the corneal stroma, resulting in a conical shape, versus keratoectasia is progressive steepening and thinning and an abnormal protuberance of the cornea after refractive surgery. So we just want to go over, I don't think this gets touched on enough, but just looking at irregular astigmatism. The picture on the left is a normal cornea. So I call it baseball shape here in the US because we have baseball, but throughout the world, you can definitely come up with some type of grain. Regular astigmatism is when the eye becomes a little bit more abnormal or elliptical. And irregular astigmatism is just when one area or the principal meridians are not 90 degrees apart, so you don't have this and this. A regular cornea, this is a schematic on the right here. It can be irregular astigmatism, corneal ectasia. It can result from a corneal transplant and corneal dystrophies, as well as ocular surface disorders. So we tend to think of just corneal ectasia as being irregular, but really all of these can be causes of irregular corneas as well. Irregular astigmatism, again, corneal transplants, intacts after surgery, and then as well as trauma and globe, such as a globe repair, which is the picture here, or a penetrating wound, which is a picture on the right. Corneal dystrophies can also cause irregular astigmatism. I know this is not part of keratoconus, but I want to distinguish these two. The common dystrophies, epithelial basement membrane or recurrent erosions, but other corneal dystrophies can also cause irregular astigmatism. So with respect to keratoconus, epidemiology, it's typically asymmetric. A key point is that 50% of the patients who are diagnosed progress within about 2 years and 83% within 6 years. It's associated with eye rubbing. So those patients that really want to get in and dig their eyes out, they have atopic conditions and or connective tissue disorders. Prevalence, this is changing a lot. I used to call it 1 in 2,000 or 50 in 100,000. The RAIN study that just came out has increased it. So I guarantee this slide will be changing in the next couple of years. Onset is typically puberty with progression until the 3rd or 4th decade. And I'll talk a little bit more about that later on. And a family history, roughly, you can easily gauge 10% will have relatives with a similar condition. It's also associated with patients who have Down syndrome, Ehlers-Danlos, and osteogenesis imperfecta. Environment plays a key role. So most of your patients with keratoconus will have other conditions, a lot of allergies, asthma, and atopic conditions. Family history, as I mentioned, the inheritance pattern and genes associated with keratoconus. It's not widely established yet. There's a lot of linkage and associated studies. The LOX gene is associated, and I'm just going to run through all of these because there is a number of genes that are associated. So it has no specific gene that we can target. It's a combination of several genes, is my point here. Again, chances of blood relative is roughly 10%, 8 to 12%. So again, these are the genes associated with it, the variants. It's something that is widely being studied right now, but again, we'll know more in the next, probably the next decade, we'll be able to tell a little bit more. So histopathology, the pathogenesis, more or less you have an altered elasticity of the cornea. You have a loss of anterior stroma, and the anterior stroma becomes highly impacted or more compact, sorry. And it's more resistant to, it's maybe more resistant to mechanical deformation than the posterior stroma. It causes an intrinsic collagen weakness. So types of keratoconus. Philippine is one of the ones that eluded me for many years. It's basically an incomplete manifestation of the disease. You can have one cornea with no abnormal findings with the fellow eye with keratoconus, or slight corneal findings with little or no impact on quality of vision. Generally speaking, these patients are usually the relatives, or they don't even know that they have it. For Philippine, you're going to have just a little bit of abnormal topography. So it's just going to be a very hint of that hot spot on the keratoconus, or on the topographies is usually where you're going to find it. Or the other place you'll find it is maybe the patients have just a little bit of astigmatism that it's at an oblique axis. Keratoconus, the actual keratoconus, symptoms include loss of uncorrected visual acuity, visual distortion. So these patients, again, that's why I have this picture here, they will complain of polyplopia, where they're going to see multiple images or ghost images on top of each other. Your retinoscopy, you're going to have scissor reflexes. So everything's going to go a little bit crazy because you're reflecting off of a very abnormal cornea. Progressive refractive error, astigmatism, high astigmatism, and usually it's not going to be at the principal meridians, and loss of best corrected visual acuity. So I like to use this visual. I have to credit Jan Bergmanson, who is my mentor. He kind of equates it to a beer belly. So keratoconus, you can see that you've got that central thinning right at the apex. This is a little bit more moderate, but if you do your slit beam, you're going to see that thinning of the beam. And again, this is a more pronounced keratoconus, but again, this is just mimicking your slit beam. I have to credit Dr. Lynette Johns here because she provided me with this slide. But again, this is just showing your beam and how you're going to just see that thinning right in the center and in the apex where the most amount of thinning is going on. So keratoglobus, very rare. You're going to see complete thinning of the cornea. It's going to be the entire cornea that is going to be consumed with the keratoconus. It's primarily considered a congenital disorder that's present since birth. With keratoglobus, you're going to see, again, this is going to be, you can tell from this slide that you've got the blue sclera right here, which is one of the pathognomonics. And also just you've got keratoconus throughout the entire area, not just one particular area. Pellucid marginal degeneration, this is usually going to impact the inferior cornea. It's commonly diagnosed between the 2nd and 5th decades, and it affects all ethnicities. The prevalence is unknown. And right here you can see that you're typically going to have your kissing dove or your bear claw or crab claw or things that you want to look for. But this is just hallmark of how your topographies are going to look. I find that most patients get diagnosed in their late 30s, 40s. So that's one thing that I personally experienced. I don't know that I've ever seen it in a patient as young as their 20 and 30s. Early signs of keratoconus, a Fleischer ring. I've got 2 pictures here. Fleischer's ring is just an iron ring, and it can be really hard, but if you start looking for it, once you start seeing them, you're going to be able to see it. Some people prefer to use a cobalt filter to look for that iron ring, but basically you've just got iron deposits collecting over the top of that apex. Again, you've got the stromal thinning, which is shown right here, and Vokes striae, which are typically vertical. And I think of like saran wrap tissue kind of being pulled is the way I would describe it to when I'm doing teaching. Later clinical presentation, apical scars is one of the common. Munson sign, when you have the patient look down. Rizzuti sign is kind of an older way of looking at things, where you take a pen light and you can see again over here that you're going to have that conical shape. It's kind of more fun to look at, but typically at that stage, you're going to know that the patient has keratoconus. Late clinical presentation is high drops. So these patients, because of that thinning, I call it a blowout, where the cornea just couldn't withstand. Most of these patients will call suddenly with a white cornea and they have a diagnosis of keratoconus, or hopefully they did. It's usually something that's you're going to see. There isn't much you can do about it till later. Most of these patients will have to have a corneal transplant, but it looks just like this picture. High drops, risk factors, allergies, eye rubbing, traumatic application and removal of lenses because you've got such a thin cornea usually. Complications, leaks, perforation, and infectious keratitis. So patients that have high drops, there is a risk, but it's typically quite low. A summary of ectasia. So keratoconus, it's usually the onset is within the teens. It's progressive, and the thinning is apical. Pellucid marginal degeneration, again, 2nd to 5th decade, but I have commonly seen it usually when patients are in their 40s or maybe late 30s. Superior to inferior thinning. Keratoglobus is present since birth. Again, I think in my career, I've seen one keratoglobus patient, and that's the entire cornea. Topography and tomography, I just want to briefly go over it. I don't know if everyone has access to these types of topographies. Placido disc is one of the older versions where you have annular light source, so the rings shown in the top photo. It's the ring that is cast on the cornea, and you can start to see that the images or the rings will kind of coalesce around the apex. It's reflected on the cornea. Scheimpflug, there's a couple different kinds. This is my preferred method. It's a bit more expensive. There are images captured on both sides of the cornea, so the front surface and the back surface, and it's not dependent on tear film. Going on to map types, 3 common types: axial, tangential, and elevation. So axial is going to give you an overall more global view of the shape of the cornea. It's kind of more of a best fit sphere or based on the average cornea. So it's based on an algorithm. Tangential is going to give you more definite points. So points next to each other. It's seen as more accurate curvature and location. So you can see these photos. This is the same cornea, but the top is an axial map. Again, it's just kind of like averaging everything out. A tangential map is going to give you more defined points. Again, axial versus tangential, you're going to get more kind of a global look at things versus very pinpoint things. I personally like axial. I think there are many people that will prefer tangential. I like to look at the general shape of the eye, but the tangential can be helpful if you're having maybe some troubleshooting on like a gas permeable lens. Pentacam is my favorite. It's really the most expensive. It's the most expensive of the topographers. It gives you a lot of information and it spits it out in any form that you want. There's multiple display options, but what I like about the Pentacam or Scheimpflug in general is that it gives you a look at both the front curvature and the back elevation. So the front elevation and the back elevation. That's going to give you more data points with respect to keratoconus or form frust. Usually for form frust, you're going to see on the back surface elevation just that hot spot, and you're looking for just the comparison of the front and the back surface. The other thing I like, and I'll talk about more of this later, is that it gives you central corneal thickness, which can be used for tracking and progression over time. So with respect to topography, there's something called the Rabinowitz Kisa index. Basically, if you have a difference of between the inferior and superior cornea of 1.4 diopters or a cornea greater than 47.2 diopters, that is suggestive of keratoconus. So management of the patients. So initial discussion, the initial diagnosis is key. It changes whether it's pediatric patients, adult patients. There is genetic testing available. I'm not sure if it's available worldwide. I had a slide on this, but I took it out just because I'm not sure whether it's readily available. And then resources for patients. So clinical decision making or the decision tree. So based on patient characteristics, patient expectations, and long-term course of care. So your management of the patient is going to change based on how old they were when they were diagnosed, whether they're pediatric below 12 years of age versus 18 versus 30. And then patient expectations and characteristics can be key on that's probably the most difficult part to learn and the most difficult part to teach with respect to managing keratoconus. So patient expectations are key. A lot of times when I get a patient in the chair, I kind of open up with open-ended questions. I ask them to, if they don't know about their disease and they've been referred to me for a contact lens fitting, I ask the patient to clarify what they know about their condition. This allows me to gauge. A lot of keratoconus patients have read the entire internet, I'm convinced. So one of the important things is to clarify, where are they at with respect to the acceptance or knowledge of the disease? And then I always try to clarify any information where they may have kind of gone astray, or if maybe they don't have a clear understanding. Some patients come in and they have no idea what to expect. They have no idea where they're going with things. So this is key, is you just want to make sure that you and the patient are on the same page before you even get started, because one, you want to win them over. Two, they typically have a lot of anxiety about their condition. These patients are young. They have a lot of years ahead of them. And my common thing that I find with patients is their biggest concern is blindness and risk of blindness. And that's the cool thing about our field right now, is we really are able to make a huge impact on patient lives here. And I'll talk more about resources at the end of the lecture. For me, it depends worldwide, and obviously insurance may not be a factor for some people, but we like to go over exam fees, fitting fees, insurance authorization process, and policies. It's best to go over these things up front if you can. Some of you may have the luxury of being able to have ancillary staff to go over things, but it's really key to be able to have these upfront conversations with patients. Most important is the fitting process, that they may be coming in several times. And the policies with respect to lens warranty are probably the biggest things that I would encourage you to talk to your patients about. So contact lens options, there's so many options, like I mentioned, and I'm going to go over each and in every single one of those. Don't forget about glasses. The reason I say that is patients who are correctable to 20/20 with glasses, they don't necessarily have to be fit in a contact lens. I get a lot of patients that are referred to me, and maybe they're forme fruste, or they're a mild keratoconus, or they're functioning okay, and don't have any complaints. We don't need to force those patients into a contact lens. The other key component, though, is with respect to glasses, you should always make sure that the patients have some type of glasses. Even though glasses don't always work for patients, there's going to be conditions or circumstances where they can't wear glasses, can't wear their contacts. And so that's when I recommend that we have something for at least navigation purposes too. So don't get so tunnel visioned on your contact lens fitting that you forget about the glasses option. And I've had so many patients that were referred to me, they see 20/20, and with their glasses, I tell them, you're fine, reassure them. I'll see them annually. You monitor them just like you do with all of our patients. So again, soft lenses are there. You can use that for keratoconus. You don't have to fit the patients in a gas permeable lens. You do not have to fit them in a scleral lens. There's so many toric options. I personally have a lot of astigmatism, so that's actually nice because I can explain that to my patients on how they see and relate to them. There's certainly extended range soft toric lenses that are now widely available in the XR category. There's also specialty soft cornea, soft contact lenses for the irregular cornea as well. Soft contact lenses, again, are good for mild keratoconus or newly diagnosed patients. I find this to be a really good option for patients that are usually low to mid 40s on one eye, or they have the forme fruste. The indications, you can use it for everything. So you can use it for normal corneas, keratoconus and pellucid marginal degeneration, as well as keratoglobus. Again, I've been most successful in the mild to moderate keratoconus patients. One of the things that I have in here with respect to Kerasoft is a brand that's available. I put up this slide particularly because they have their algorithm on how to fit Kerasoft lenses. But if you think about it and if you read through it, it's no different than how you evaluate a soft contact lens. So you're looking for movement, you're looking for rotation, making sure that the lens is centered, comfortable, and then vision is stable. So my point being, and I have to credit Lynette Johns here, is that she was the first person to point this out. Like, I get so lost in looking at the fitting guide for the soft lenses, the specialty soft lenses, and really it's back to basics. You're just looking at how the lens fits on the eye as it relates to a soft toric contact lens. So keep that in mind with these. Don't make it difficult. Why soft lenses? They're comfortable. They're more comfortable for the patient versus a gas permeable lens. Ease of handling, lens centration is usually going to be pretty good for those mild patients. You can do a diagnostic fitting in office, and there's less intimidation from a practitioner point of view because the patients are going to tolerate the lenses usually almost immediately. Some of the soft lenses are going to be a little bit thicker, so you do need to let the patient know that it's common for them to be able to feel those lenses. Hybrids for keratoconus are also a good option. The three that I have listed, the Ultra Health, Clear Cone, and Synergize, are the ones that are available here. Synergize is more for regular corneas. But you can, with the Synergize ID, they can be fit or are fit completely empirically, meaning you can call in to them with your refraction, your keratometry readings, and your horizontal visible iris diameter. UltraHealth and Clear Cone are designs that are more commonly used for keratoconus, where you vault the cone or slightly touch the cone. They have really come a long way in terms of how they have increased the decay, the oxygen permeability, and also the skirt. There was a huge problem early on with these types of lenses because the oxygen permeability of the soft lens part, the skirt, was an issue for a while where patients would develop neovascularization. Again, that's less of a problem since they've come into modern technology. Corneal gas permeable lenses. These are probably the ones that many of you use, and I think it's still the most commonly used type of lens worldwide. You certainly have the option to do spherical or your own bells and whistles, but the proprietary designs such as the Rose K and the Comfort Cone, these guys have done a ton of work in trying to figure out what is the common characteristics of a keratoconus eye. So they've already done all the hard work for you with these proprietary designs. You can use a spherical lens, so don't think that you can't use your just traditional fitting set, but I find that proprietary designs such as the Rose K and Comfort Cone are great options. Interlimbal, I'll talk more about those later. Interlimbal I use more for post-surgical, post-PK eyes, and sometimes for pellucid marginal degeneration. So corneal gas permeable lenses, again, it's going to be a hard material. Excuse me. So it's a rigid lens. It incorporates gas permeable designs. Again, that lens is going to kind of fill in all the nooks and crannies of the irregular surface of the eye. It's dependent on the tear film. It requires tear exchange. So when you're fitting it, just make sure that there's movement and the edge profile is enough to allow for tear exchange. It does require, in most cases, it requires a diagnostic fitting, and it's effective for visual rehabilitation. The problem with corneal gas permeable lenses is adaptation can be a problem. So the best way that I've described it is Dr. Jen Harthen was the one that credited or gave me this idea, is that it's kind of like wearing a watch, where at first your brain's gonna be aware that the lens is on the eye. And we would typically or traditionally build up wearing time with these patients. So over time, they'll adapt to it. And eventually, like the watch, your brain will start to ignore everything. So gas permeable fitting flow. You want to know what type of cone you're working with. So nipple, oval, or globus, and whether it's mild, moderate, severe. We know from the CLEC study, less than 45 to 52 is moderate, and greater than 52 is considered severe. And then overall diameter, which I'll talk about more in the next slide. Base curve and fluorescein pattern are so basically this slide is going through the thought process on how you need to determine, or what you need to use to determine what's going to work best for your patient. So for corneal gas permeable lenses, diameter selection is based on the severity of the keratoconus. So mild cones are, you're usually going to have a larger diameter lens. For steeper, you're going to go a bit smaller so that you're kind of honing in right over the keratoconus, the apex of the keratoconus. And again, this slide is just going through, mild, bigger, more advanced, steep. And again, those proprietary fitting sets are reflective of this. So if you go back and open up your fitting sets, you're going to see that the flatter base curves are going to be the larger diameter, and then the steeper base curves, and for the more advanced cones, are going to be a smaller diameter. So everyone's going to go to their clinic on Monday and take a look at this. For gas permeable lenses, again, with oval or globus cones, so So those are the cones that are going to be more like your pellucid, or you have the majority of that thinning and steepening more inferior. You're usually going to use a larger diameter the more steep the lens gets. The reason for that is because your gas permeable lens is always going to find the steepest part of the cornea. And so if the lens is dropping, then you don't want that patient looking through the edge of the lens, or kind of the gap between the edge of the lens and the optic zone. So if you go bigger, you've got a larger surface area to look through. Base curve selection. Always, if you're using a gas permeable set, you can just open up that fitting guide. They've done all the work. Use your resources. There are several different philosophies. If you don't know where to start mid-K. You'll usually have apical bearing, and then you'll go up from there, but fit steeper so you'll continue to move up on your diagnostic fitting until you see that slight apical clearance. If you go based on the steep K, you're going to have pooling over the apex. You're going to get a little bubble, and then you go backwards. So the best way that I found is, if you don't know where to start, either start on average K for gas permeable lenses, or pick the middle lens in the set, because you've eliminated half the set one way or the other when you use that philosophy. So if you get into clinic, you forget everything, average K, or pick that middle lens. There's 3 different fitting philosophies with gas permeable lenses. Flat, I don't think many people use this much anymore. There was a misconception that if you fit flat, you're going to slow or halt the progression of keratoconus. We know that that's not true. You are flattening that cone a little bit, so you're going to get a more spherical lens or spherical cornea. So it is going to look a little bit better in terms of the outcome of improved vision. But if you're bearing on that cornea, you're probably going to run the risk of a scar formation. If you fit steep, again, it's going to protect the corneal apex, but you're usually going to have go over that central apex, but then the periphery is going to seal off, and you can run into tight lens syndrome, or in which case you have that lens is completely sealed off. And in some cases, the patients can end up with iritis. So we definitely don't want that. You want kind of a mix of the two. 3-point touch is really the mix of the two. So you have a balance where you've got a feather touch over the apex, and then you're resting on 2 mid-peripheral areas. You're distributing the weight evenly, and this has been determined to be the safest. So basically, you're looking for 3 points where you don't see any fluorescein. Scleral lenses, we've seen, at least in the last decade or even more, that these have become an increased use for all types of patients. The advantages are it vaults over the irregular cornea. It rests on the less sensitive tissue, on the conjunctiva. It still has the same optics as a gas permeable corneal contact lens, and centered optics, and again, more comfortable because you're sitting on the conjunctiva, which is less sensitive. Advantages and disadvantages. Initially, you have better comfort than the gas permeable lenses. So most of those patients right away is going to be comfortable if you have a good fit initially. Again, great vision. You're able to fit all different types of keratoconus. They're quite durable. The way that I tell my patients, they are durable, but they are breakable. So they're great in the sense that I've had my patients wearing the same set for several different years, but they are like I equate it to a plastic spoon. If you drop the plastic spoon on the floor, it's not necessarily going to break, but if you drop the spoon on the floor and step on it, it is going to break. You have lots of different options and a lot of different bells and whistles that you can incorporate. I will not usually do multifocal unless the patient is milder keratoconus or is capable of 20/20 vision. But that is an option for your patients. The disadvantages of scleral lenses is there's a learning curve for insertion and removal. So these patients can be a little bit intimidated, but once they get it, it's kind of like riding a bicycle. Most of my patients use the adapter, so the plungers that are shown here. The cost can be much more expensive initially for patients. So those are the biggest disadvantages. And again, they can break. And so if they're more costly and they break, then that's more out-of-pocket expense for your patients. Again, the advantages, it's ease of fitting. There's so many different ways to fit a scleral lens, and I'm not going to go into it because you have other lectures that are talking specifically about it. Usually it's minimal fitting time. You have success initially, very little impact on the cornea. The patient is typically comfortable and you can get repeatable replacements. So next we're going to move on to surgical considerations. Looks like hopefully I'm doing okay on time. So cross-linking has been a huge game changer in terms of keratoconus. So I'm going to talk a little bit more about that. With respect to the timeline, what are you looking for? Pachymetry, so that central corneal thickness and the thinnest area of the cornea, you're looking for changes of that over time, changes in the keratometry readings over time, changes in your topography, which again would be the keratometry and the pachymetry, and then refractive error changes. But I find this to be the least beneficial in terms of gauging these patients and whether they're progressing or not. So in 2015, there was a group of really famous physicians that got together and came up with a global consensus for keratoconus and ectatic disorders. This is a wonderful paper if you're interested in reading. It came out in Cornea. But basically they devised a way to look for progression in keratoconus. So you're looking at at least two of the following parameters. So steepening of the anterior and posterior cornea. Again, you need, most likely you're going to gauge this from a topographer. Thinning or changes in pachymetric rate of change. So again, on every exam every year, make sure that you have a place where you're documenting that central corneal thickness as well as the thinnest point, and you're looking for changes over time. And then progressive changes of the pachymic distribution. So thinnest corneal point is going to change over time. So cross-linking was developed in 2003. It's minimally invasive, and the goal is to halt the progression of keratoconus, not to eliminate it. So that is the key thing that you need to talk to your patients about. It's meant to stop it from getting worse. It is not going to eliminate keratoconus. A lot of the patients will think, oh, if I just have this surgery, I just have X surgery, I won't have this condition anymore. You need to clarify that with your patients that that's not what the goal is. And I cannot emphasize that enough. There are off-label uses of cross-linking for post-op ectasia and treatment of ulcers. Ectasia at the University of Michigan, we do use it, but I don't think I've seen it used yet for corneal ulcers or scarring. So what's the concept behind cross-linking? You're using ultraviolet light and it induces and you're using riboflavin, which is placed on the cornea. It causes a cross-linking, an increase in covalent bonds. And with the tighter bonds, you have a stronger tissue. So it's less resistant to break down over time. Inclusion criteria. I don't know that everyone has an EDTRS chart available. So this is probably a little bit more didactic, but basically you're looking for changes in the best corrected visual acuity. But again, that's very subjective. The patients must be at least 12 years of age. For corneal ectasia patients, they must have a diagnosis of corneal ectasia after refractive surgery and an axial topography consistent with ectasia. So patients who have had refractive surgery, we need to look for that steepening. For keratoconus patients, you just need topographic evidence of mild, moderate, or severe keratoconus, and a maximum corneal curvature by the steepest K max, or the steepest K, to be greater than 47 diopters. For contact lens wearers only, you have to have a manifest refraction stable between 2 visits, which occur at least 7 days apart. Contraindications, this is key. So patients who have more than 60 diopters are not candidates for keratoconus. If the cornea is thinner than 400 microns, it's not a good idea to send those patients. You may want to send them and just let them know that they may not be a candidate. I always let the surgeon make that decision, but that's something that you wouldn't want to consider. And then deep scars are not candidates. So a couple things though, patients with the gray area for me is patients who have vision better than 20/40. Clear corneas and vision better than 20/40 have a risk of developing corneal haze. So that's one thing that is probably for me, one of the things that I'm looking at even before I look at the other contraindications is that vision and what they're capable of. So complications, I think this is really the most major study that came out, looking at 105 eyes where they evaluated these patients who went through corneal cross-linking. Most of them had a 1 diopter increase over 6 to 24 months. 84% had stromal haze at 1 month post-op. I'm not clear on the amount of stromal haze and whether that stromal haze was able to be treated with topical steroids. Sterile infiltrates and scar developed that didn't correct the best corrective visual acuity. 2%, 3% lost 2 lines of best corrective visual acuity. More than 35 years of age. And again, the visual acuity being greater than 20/25 were evaluated as being risk factors. And then roughly 8% had more than 1 diopter increase over time. So again, that 60 diopter or 58 diopter was a risk factor over time. If you take out the patients that were over 35 or vision was better than 20/25, though, the risk of complications for corneal cross-linking was 1%. So that's really important. So 35 and then looking at that vision. ABCD progression display is I think it's only available on the Pentacam. I'm not sure about that. But this is a way that our surgeons use to look at the progression of keratoconus. It's a grading system for cross-linking. It's objective. You're looking at the central 3 millimeter around the thinnest point. The A stands for, so ABCD. A stands for the anterior surface, which is something that's capable of being captured by the Pentacam. The back surface, the posterior float. Central corneal thickness is something that they're looking for, and distance acuity. So the surgeons are going to look at that. It's going to, this type of progression display shows every time you take the Pentacam, it's going to show that in one particular area. So you have all that data right in front of you. The timeline for fitting, this is the $1,000,000 question right now. Basically, once they've been deemed stable by the surgeon, so Ks aren't changing, vision isn't changing, the patients are going to be referred back. Most of my patients, I've been able to make use of the same lens. You might have flattening of the cornea, so you may need to change that fit. And you're usually going to have a change in the over refraction for those patients. Intacs, these are another surgical option. I am not a fan. I will come out and say that right away. The idea is that you've got these little plastic spacers that are inserted into the cornea that can kind of flatten the cornea and provide better support for the cornea. I think the advantages are that it's reversible and it's safe without impact on the vision, and it can improve visual acuity on patients who have contact lens intolerance. I don't know if any of you have fit over a gas permeable and particular lens over Intex, but it's not fun. You're kind of fitting over an obstacle course at that point. Again, more surgical considerations, corneal transplantation. This is a schematic just looking at all the different layers, and basically that's what it comes down to. Are they, what part of the cornea? So penetrating keratoplasty is the entire cornea. A DULC is going to be the anterior lamellar, so just a little bit farther into the stroma. And then your DSEX and DMEX are going to be the endothelium. So penetrating keratoplasty is still probably the most commonly worldwide performed transplant. Basically, the surgeons are taking the entire depth of the cornea, cutting out a button. The risks are that the patients can have hemorrhages and prolapse. Post-operatively, these patients can have retinal detachments, endophthalmitis, glaucoma, cataracts, graft dehiscence, graft failure, and graft rejection. Graft failure and graft rejection are the biggest ones. Oh, I better start moving faster. Anterior lamellar is basically just taking the a little bit farther down. So this is the front part, just the front part of the cornea, and a little bit more of the lamellae. So a little bit deeper. Falk is basically using the femtosecond assisted laser keratoplasty, which was developed at the University of Michigan. Endothelial, again, this is not commonly used for keratoconus, more for Fuchs endothelial dystrophy. I've seen it for graft failures where they take just the back part of the cornea and they're attaching that to the eye. Clinical practice. So one of the key things that I found or was a little bit of a difficulty over time was, when do I send these patients for surgery? So keys are if the patient does not achieve better vision than 20/40, if the patient has exhausted all contact lens options, or if the patient is intolerant to contact lens. Let the patients know, and this is another key discussion point, is that these patients will have, they think that if they get the transplant, they're going to eliminate the keratoconus. And patients may end up in a specialty lens after surgery. So definitely have that conversation before we refer it, and hopefully your surgeons are having that discussion as well. Long-term care, it can take up to 6 months because these patients are having suture removal. They're going to monitor the patient for graft failure and rejection. The more transplants you have, the shorter the lifespan of that graft will be. And the patient's endothelial cell count will start to go over time. With respect to graft shape, you can have prolate, which is, I'll go over that in the next slide, oblate or mixed types of surface. So for graft shape, prolate is just going to have that more positive shape. Oblate is going to be flatter centrally, which is why you have that blue spot, and then steeper peripherally. And mixed is probably the most difficult ones to fit with at least with the gas permeable lens. Again, the lens is going to slide over onto that steeper part, the red part. So those are things to consider after your patients return to you. Follow-up. This is a key. So patients who have left with contact lenses and you're bringing them back, whether it's the 1 week after dispensing the lens or 1 year, I always have my patients bring a list of questions. Ask open-ended questions. How are things going? How's vision? How's comfort? Have that patient explain their nightly care. I've had some odd things pop up lately, so you want to make sure that you fill in the gaps and make sure that these patients are cleaning their lenses appropriately. For follow-up exams, obviously you're going to test vision and over-refract. I always encourage everyone to pinhole. The next steps are evaluating that lens on the eye. For scleral lenses, you want to look for conjunctival staining and also look on the cornea just to make sure that the patients are not developing. So you want to take the lens off and make sure that the eye is looking healthy, or if there's any lens-related problems, that's an opportunity to fix those. For lens evaluation, the biggest thing that I'm looking for is I check on my radioscope on the base curve to look for warpage, and also lensometry to look for the power. If the patient's having not great vision, it's usually that if you're looking through a warped lens, so you're not going to get a finite endpoint on your lensometry. And make sure you document everything. So for scleral lenses, if they have a serial number, make sure that you document that, because your patients will come in with old lenses, mixed up lenses, and those are key things that you want to talk about. One thing, again, is that with respect to our role in terms of fitting contact lenses, it has been a game changer in this patient population over time. So if you can see that the trend is that most of these patients are not having, we're having less PKPs and corneal transplants for ectasia. You can see that's the red line there. This is one of the papers that myself and Dr. Hood published in the American Journal of Ophthalmology. And the key considerations here are that with scleral lenses, you were able to reduce the rate of corneal transplant. Another paper from Karina Kuppen out of the Netherlands, basically scleral lenses are reducing the need for transplants, and again, showing that we can have a huge impact on these patients. And scleral lenses, another paper out of the University of Michigan, some of my colleagues, their conclusion, and that's the key take-home point, is that physicians should maximize the use of any type of gas permeable or scleral lens so that they do not have to undergo keratoplasty. So in summary, identifying keratoconus and ectasias can benefit the patient by intervening and allowing the patient to be referred for cross-linking to halt the progression. There's a variety of contact lenses available for these patients. The technology has impacted and reduced the rates of surgical intervention. And if the patients are contact lens intolerance, we have multiple surgical options. And co-management benefits both you, the patients, and your practice. So a couple of resources. The National Keratoconus Foundation has some great resources. The dry eye zone for any of the cleaning. Rebecca's really up to date on everything. Gas Permeable Lens Institute, started by Ed Bennett, and the Scleral Lens Education Society is another great opportunity for you if you want to learn more. Some of these places even have handouts for patients or patient information. So those are good options for you. And I really want to thank everyone for attending today, and hopefully you learned something. Please let me know if you have any other questions.
Okay, thank you, ma'am, so much for that insightful presentation. I think you covered every tiny bit of keratoconus in terms of yeah, but really important where you started on knowing the disease and then going about looking for what are the signs, symptoms, and also what are the options for management across the whole spectrum. Starting from glasses to the advanced when we talk about scleral lenses, and also the surgical options which we need to be talking to our patients, as you mentioned, that we have to be talking to our patients. We are the frontliners in that sense to be, helping our patients in doing these things. So thank you so much, for sharing that with us. One of the questions which I think came earlier on the chat, I think you did cover it in the talk, but I'll just quickly ask you: are scleral lenses your first choice of management for keratoconus? That was the question.
It depends on the patient and the characteristics of the patient. Again, if the patient is capable of 20/20, or you can fit them into a soft lens. So if the refraction is 20/25 or 20/20, I'm not necessarily going to go with a scleral lens. in my setting, most of my patients, if they, it depends on the cost, and most of my patients have tried other options and they're being referred to me as kind of the last option. I have patients that come in that are being referred for scleral lenses and they're successfully wearing gas permeable lenses. There is no need to reinvent the wheel. If they're doing well, if it isn't broke, don't fix it.
That's right. Yeah. So as you said, it's all multifactor. You need to look at everything, and it's not just like this lens is the go-to lens. All patient would benefit in.
I mean, gas permeables have been successful for over 50 years. So there's no reason not to consider that as an option as well. The hardest part about gas permeable lenses is that usually the fitter is going to be more intimidated by it and the patient. So I always, I would recommend numbing my patients up. So prepare a cane or something to get through that initial fitting. That's my tip.
Awesome. Great. There's one question which came up about corneal transplant and things like that. So just wanted to ask you about corneal transplantation in terms of donating the cornea. So I'm just going to put that question first. What do you think is the characteristics of people who can donate cornea? Again, very off, but again, if you're talking about corneal transplant, people would want to ask you when you're counseling the patient. So do you have any tips on talking about corneal transplantation for patients?
So the patients that, is the question like when the patient is considering a corneal transplant?
Yeah, probably we can address it in that way. Yes.
Not the other way where if you're post-mortem. Okay. So the biggest thing with post or referring for a transplant, number one, I never suggest any type of transplant because that's the surgeon is going to make that decision. But number two, so you get a wide variety. You get patients that are just really fixated on getting a transplant. And the biggest thing with that is you have to let those patients know that it is not going to cure the keratoconus or the corneal ectasia. So that is the biggest thing that you have to have that discussion with the patient and make sure that they understand that. They may not understand that. They may have to hear it from 3 different people before they get it. Or they're going to go with the transplant. And then the other key element is that you need to let the patients know that they're going to need, they have about a 40 to 50% chance of needing a specialty lens after the transplant. So that's a key thing. And then also the healing time is 6 months to a year, where they may not have good vision for up to 6 months to a year. So you gotta, the biggest thing is to go over those things. Sometimes you can't talk the patients out of it though, and that's their choice and that's their prerogative. Sometimes they can't afford the lenses, so they go for a transplant. So it just depends. It's not a one shop stop kind of discussion.
Awesome, great. And any thoughts on using hybrid lenses for keratoconus? Do you?
I think it's a great option.
Are there good options?
No, I think it's a great option. Again, it just depends on the patient. Usually, I'm more likely to do gas permeable or scleral lens. But if a patient's having like intolerance to a gas permeable lens, I will either, and I didn't talk about this, but a piggyback, so sliding that soft lens under the gas permeable lens, or the hybrid lens is another good option. And then it can also be a good option for patients that have a little bit of dry eye with the keratoconus because the optics are very good.
Right, great. Yeah, it gives a good optics as the RGP. So, the GP lens will provide good vision for that.
Mm-hmm.
Okay, a couple of more questions which just came in. Let's say the cornea is less than 400 microns. Would a corneal cross-linking would be performed, or are there such guidelines in terms of corneal thickness and cross-linking?
So 400 is the limit. Sorry, I didn't mean to interrupt you.
Yeah, no problem. Yeah. And the following question is, how much contact lenses would help while performing cross-linking? So post cross-linking, probably, is that contact lenses would be useful? Is there something different? I think you did cover that as well.
Yeah, usually This is it's a really, really good question. And we don't know exactly because some of the patients, they're coming in midway, so they already been fit in a lens, and then you send them for cross-linking, and then they come back to you. It's kind of a mixed bag because some of the patients, in theory, you're going to have a flattening of the cornea, but it depends on the patient profile. So that's a gray area that I don't know that we have much literature to support any defined outcomes. So stay tuned.
Right. Yeah. And evidence is evolving each day, I would say, and we are getting new information and helping our patients. So we need to keep ourselves updated. Right. Let's take one last question before we end this session. And this is regarding what are your favorite subclinical type of keratoconus, and what are the lenses you think you would recommend for this strong crystal appearance?
So form first, usually these patients aren't even going to know that they have a problem. So they're usually going to be fine with a soft toric lens, most likely. Or they have one eye that has the keratoconus and the other is just marginal. So that goes to practical. So if you can fit both eyes in the same modality, that can be helpful because of cleaning and nightly care. I've had patients where I've done a mix where one eye I do keratoconus fits and then the other one is a soft lens. I've had patients that have a lens in one eye and then just wear glasses over the top. So it depends on what you get as your end point with those patients. If they're capable of 20/20 again with the glasses, they're fine. The biggest thing is probably looking for other relatives. So that's when you have the discussion about relatives and that 10% risk.
Right. So that will be useful in terms of managing the overall expectations for the patient as well. Right. Awesome. Great. So I think with that, we have taken all the questions which came up in the chat. Thank you so much again, ma'am, for this wonderful talk and spending your Sunday morning with us today.
Thank you. I hope you guys enjoyed it.
Definitely we did.
All right. Bye.
So, bye-bye. Thank you so much. We do have session planned over the next couple of weekends and wish to see you again in the next session. Take care, be safe, and bye-bye. Thank you, ma'am.